in a situation where, as you say, a highly undesirable situation,
Yes.
where of necessity you are finding yourself discharging COVID patients into this very vulnerable environment, then, as Ms. Rowton said, strict infection control
Absolutely.
is obviously important. And would it be fair to say that it would therefore be necessary to make sure that care homes had proper guidance, and for that matter, maybe mandatory regulation about the clear steps they should take when they are receiving into these care homes infectious patients?
Well, we might come on to the mandatory regulation. I mean, I think the issue here is, as I think Professor Van Tam gave evidence before, this is just trying to set out, this is the top line, awful prospect of what could happen with this number of cases. But the reality is, and I think Professor Van Tam noted, that any person who is discharged into a care home, whether they are positive or not, if they've come from an environment, actually, whether they've had a test or not, it's actually the infection prevention and control measures which are the critical component over an incubation period. So yes, I agree with you in principle. I think we get hung up sometimes on the test, whereas in fact it's the IPC. So I agree with you in principle. The mandatory bit we might come on to.
Well, or maybe in another module.
Yeah.
Let's look briefly, Professor, at the guidance, the care home guidance that was in force at the time, and there were different sets of guidance being published at around this time, were there not? But if we can go to 300278, we see that this, if you can see just below the title, COVID-19, it was published on the 13th of March, so in fact only 3 days before the email we've just been looking at. And if we can go on, please, to page 4 of that document, we see at the top there, the title, If a Resident Has Symptoms of COVID-19. Just before we look at the paragraph, Professor, one might have thought, judging by the email and the understanding that, of necessity, care homes were due to receive these possibly large numbers of infectious COVID-19 patients, that they would be told that this was coming and that, as Ms. Rowton said, very strict infection control measures would be needed. In fact, well, you tell us whether what we see here is consistent with that, but the message is care homes are not expected to have dedicated isolation facilities for people living in the home, but they should implement isolation precautions when someone in the home displays symptoms in the same way as if that individual had influenza. If isolation is needed, a resident's own room can be used. Ideally, the room should be a single bedroom with ensuite facilities. Looking at this now, do you think that that type of guidance was appropriate to circumstances where it was understood that care homes would be receiving possibly large numbers of infectious COVID patients?
So I think we just need to draw a distinction that my message on the 16th was, as you've noted, numbers go up. This was a just look ahead and think this is what will happen in due course. It doesn't give a time frame. And I think on this one, there had been, I think the first case in a care home was around the 10th. And I think this guidance actually had been held up from the 7th. It's not, I'm not sure I've signed it. I did comment on a lot of guidance, but I think, I would have to check, but I think it was PHE guidance and not one that I finally signed off. That doesn't detract from the question. So I think there was new guidance coming through as cases started to rise. So I think as I said, I think the first case was on the 10th of March. So the critical thing here actually is the isolation, that you should not take my email as to say the NHS is suddenly going to discharge lots of COVID positive patients and that's absolutely fine. What it was doing was painting a picture to the person who was contributing to policy on the official side at the Department of Health. And the isolation issues, I mean, there'll be a number you may come on to around how you deal with an outbreak in a care home. But this is sitting on top of, because of the Jonathan Van Tam knowledge, if you like, in that paper over many years, relatively well-known systems of infection prevention control in care homes where it is well exercised. And I think that's another issue.
Just looking at that on its own, though, that's not enough, is it, to give the care homes the guidance, the clarity, the information that they would have needed facing the type of situation that is described in your email?
So I think there was other guidance that was published alongside this, as far as I remember, and the guidance was updated very regularly. I do think there was a problem in the sense of ensuring, and I think I flagged this in my email somewhere, which is I think that the NHS and social care should be seen as a total continuum. They are all part of the health care system, and sometimes one bit gets developed separate from another, and you can, I know looking back at some of these, you can see that a piece of NHS guidance pops out and then somebody else is trying to ramp up with it. So at the time, for the patients who were being discharged, for the background epidemiology, it is probably reasonable. But as I say, that progressed, the guidance progressed as we went forward. I'm really keen to emphasise my email was a high-level view, so people were aware of what was kind of coming over the hill, but the hill was still a little way away.
All right. Let me ask you about a separate but related issue, Professor, and actually for this purpose, let's briefly go to Professor Van Tam's paper. So it's 269388, please. And it's page 3. And we can see if we look at the very bottom of the left-hand column and then read over to the top of the right-hand column, the paper draws attention to a very particular problem in care homes, which, again, I understand from your earlier answer was equally well known. It says, although the role of asymptomatic people and those with only mild symptoms in spreading influenza, in that case, is uncertain, healthcare workers often continue to work despite having symptoms. They may act as a source of infection to those in their care. There's a reference to a Swedish study where nursing home aides are shown to be the occupational risk group, at significantly greatest risk of continuing to work despite the feeling that in light of their perceived state of health they should have taken sick leave. In reality, the employment status of many staff is often precarious. Taking unpaid sick leave may result in adverse economic consequences. You're nodding, Professor. Was this another equally well-known aspect of the healthcare risks associated with care homes, nursing homes and the like?
Yes, I shall have to make sure I stick to my profession. I mean, the social care sector, as I've said, I think is under-recognised. There are more people employed in it. I think around 25%, more people employed than in the health service, is my understanding. Around 25% of them, I think, are on 0 hours contract. Many of them, the majority, are women.
Professor, can I just interrupt you? Could I ask you to try and speak a little more slowly?
I will do, sorry. You can tell that I care passionately about this. And therefore, when you want to manage situations of infection control, it's really important. It's similar, actually, in some other industries. So, other settings, for example, like food factories. I'm not suggesting these are the same, but the same issue of people working in poorer circumstances who cannot afford to take the time away from their work. And often it's compounded because both halves of a couple, for example, will not be able to. And if there are children at home, they're not receiving free meals. They can't do that either. There's a whole sequence of social events which, for very understandable reasons in those families, would predicate to people either continuing to work, which of course is a risk to those for whom they're caring, or for things like, I think, not staying in confinement and isolation.
So the problem is, and I think on your evidence was well understood at the time. And if we focus then on that email of yours, and I'm simply using it as a way into this discussion, we understand it was an internal email, but with the prospect then of discharging into care homes infectious patients, of course, one risk is that they themselves might spread the infection to other patients. We've talked about that, but there was just as much a risk that healthcare workers would come into contact with them, and then the workers would go on to spread the infection either within that home or indeed in another care home. Do you think that that side of the risk was sufficiently understood and sufficiently accommodated in 2020?
I think it was understood. I think it's difficult to quantify. And I would also add part of the problem here is that at the end of the day, my view is care workers are often absolutely critical in individuals' lives. They're the one person who is standing by them at their frailest moment. And there aren't many of them around. And there comes a point where you say, and we did see this in a few occasions in the pandemic, where the workforce capacity was insufficient to care for the individual. So if I just paint a picture, perhaps, where you have care workers who may be a risk, and the evidence suggests they were doing a fabulous job, but they were bringing in, as the majority ingress route into care homes, infection, that you can't just exclude everybody and people who, because you lose the capacity to continue. And one of the biggest risks was care workers, so maybe a nurse, for example, working in the acute sector, who then goes and does a night in a nursing care home and then goes on and does a bit of domiciliary work, and you can see the infection tracking round. But just saying stay in one place immediately means you've lost 2 capacity points in your health and care system.
That's a description of the problem.
Yes, it is, I agree.
So my question is, in this emergency situation, where, as you tell us, these risks were understood, was enough done to try and mitigate that problem?
So I think the problem was understood. The reason I explain the problem is because it's a very, very difficult one to solve. Because if you just isolate care workers completely and clamp down on everything, a care home might fall over, if you like, if you've got somebody working into care homes. So I think the care workers were given strong advice. They were encouraged to stay away from work. Clearly, as the pandemic went on, very strong testing procedures were put in, and that was really helpful. And then, in addition, payment funds. I mean, quite apart from the infection prevention control, payment to care workers to support them to self-isolate was also put in. So the problem was recognised and it was dealt with, but the precarious state of the care workforce was a problem through the pandemic.
I'm going to leave it there, Professor, and move on and ask you about another issue, equally hotly debated, and that's of face coverings. Mm-hmm. And can we start, please, by going to your witness statement at paragraph 8.125. And you note here, paragraph 8.125, and then we'll look at the next paragraph as well. And the inquiry has heard a fair amount of evidence about this, that the advice provided by the Office of the Chief Medical Officer on the use of face coverings, which developed during the pandemic, did it not?
Yes.
But you say here that as it developed, it reflected the developing scientific understanding at any given time. You say the initial position was that outside healthcare settings, the use of face coverings for people who didn't have COVID in community settings was unlikely to have a significant impact and was not recommended, and you give references to nerve tag and so on, and then also a reference to SAGE. And if we can go on to look at the next paragraph, please. You say that later in the pandemic, as the transmission characteristics of the virus became better understood and so on, there was a growing emphasis on the use of face coverings as a precautionary tool. And in the next sentence, you say the evidence base for their use in community settings was, and still is, to some degree, uncertain. Professor, is it fair to say that your own personal view, in fact, remained that there wasn't any convincing evidence that face coverings, that is not sort of PPE used in healthcare settings, but the sort of homemade, if you like, fabric face coverings used in community settings, that there wasn't any convincing evidence that they were helpful?
Not all the way through, no, and depending on what sort of face covering you had. So And this is the problem with the evidence, because much of the evidence, the effectiveness of the face covering from other infection prevention control or MPIs. So I think that's why we have a difficult evidence base. There is a stronger evidence base about the actual material, if you like. So if you have a 1 or 2 layer thin cloth covering, I think the evidence is not particularly effective. If you have, I have my colleague Jonathan Van Tam's words ringing in my ear. He always refers to army ones, but a kind of a 12-layer, I think he calls it duct material or something, but it's a different sort of barrier. So even within the face covering, there's a difference. If somebody doesn't wear it appropriately, it won't work. But I think the WHO advice, actually, I think it was around the beginning of July, changed, and I think that was around the right time, where you're starting to see is more recognition of the likelihood, still unquantified, of the asymptomatic transmission, and the opportunity, therefore, to the evidence starts to move in a more positive way. But I think there's also a difference between, which I think the CMO put in his report potentially, around mandation, recommendation, guidance, and allowing people to do what they want to do. And of course, anybody could always wear a face covering if they wanted to. Nobody was stopped. I think this issue is around which direction is the evidence travelling.
Let me show you a couple of documents, Professor, and then ask you a question about them. And they do cover that period that you've just been describing. So first of all, if we could look at 69151. So this is a document, the date of it's not on the document, but it's from May of 2020. And it's some draft guidance, as we can see, how to wear and make a cloth face covering. And if we can go to the third page of it, please. I think what we see on the sidelining is that you've made various comments. No doubt it wasn't you who did the first draft. But what we see on the top comment here, in relation to the draft talking about putting 2 squares of fabric on top of each other to make the mask, you say, just querying the logic behind needing to have 2 pieces of cotton fabric stacked on this version, but only a single layer of cotton T-shirt in the previous model. I think they're both ineffective, so I'm not unduly worried, but someone might want to think of an answer for the Q&As. So there you are in May expressing a view that, frankly, these homemade cloth face masks, 1 layer, 2 layer, are ineffective.
Because the evidence at the time said at least 3 layers. So I didn't draft this guidance. My point was the guidance there were 2 points about this. The first one was I'm querying the logic, because if I was a member of the public and looked at that, I'd think, why on earth do you want 1 layer here and 2 there? That was one point. The reason I said I think it's ineffective was because the only evidence I think we had at the time was around 3 layers, which actually started to give a bit of a positive impact. So I don't think that is effective.
Well,
if they'd said 3, I'd have said, OK, but make the guidance consistent.
Well, Professor, if there was evidence at the time that 3 layers was effective, but 1 or 2 wasn't, why didn't you say we should be telling people to use 3 layers?
Well, I'm not sure I even knew where this had come from. You have to bear in mind this will come to me from somewhere else. Often I would get given pieces of guidance that said, this is what somebody has decided to do as policy, now make it the best you can. So I may have read that one as, this is what we're going to say. And I think this is an example. So I've said, I don't think this is effective. I think the public, it doesn't feel logical as a communication to me. And if that's therefore what you want to do, work through it. I think people would have known probably at the time what the evidence was. I mean, PHE were continuously reviewing the evidence on the use of face coverings. In fact, predominantly at the time, I think it was my colleague Jonathan Van Tam.
Let me just show you one.
Can I just go back on that? Because actually, this was May, and I think this was probably the period. It was coming just after, certainly in the UK, where we'd had the Easter 6 studies and various other things. It was still not at this point. I mean, WHO was still not recommending face coverings. So we'd got a position here. I mean, maybe I was a little bit annoyed. I can see it in the tone there, but where there wasn't a clear policy, and yet I was being sent a document to sign off something which I didn't think was very evidence-based. But that was not an infrequent occurrence.
Professor Harris, I understand the need for having an evidence base. I would, given my background. And I understand that you would have preferred 3 layers because you had the evidence for three layers.
Well, the evidence with 3 layers was not very strong.
Right, well, OK, well, let's forget about how many layers.
Better.
Is there any harm in, I appreciate buying masks may interfere with supply to care home workers and people working in hospitals. Yeah. Is there any harm in encouraging members of the public to use homemade face masks? So,
I mean, this is where it gets, I think, because the evidence at this point is quite tricky. I think once we got past, I mean, as I say, I think WHO changed their guidance in July. They were not. We haven't got the date of this document. So I think where you've got a very low evidence base, it hadn't, I don't think, shifted at that point. We didn't have the evidence and still don't about asymptomatic transmission. The evidence is definitely there, is strong now, but the quantification of it is quite poor, and therefore understanding the size of effect of this is quite tricky. And this will be a government document, effectively. Again, not for me to decide, but there's quite a difference between mandating, recommending. If a government recommends something, that's quite a strong position. Encouraging, and actually if you encourage or support and you're in a government position, that's almost taken as recommending. And it's quite difficult to do that when the evidence is not strong, because you then will end up with people challenging other ones. So you tend to see where it moves to. There. But the other issue here is, if I just point out, you said, are there any other things? We've got all sorts of safety issues here as well. And one of the problems in May, and this might be related to this as well, was when, it might show why my irritation, was when there were a lot of discussions about coming out of lockdown, opening up the economy and various other things, and the 2 metre, 1 metre. I think this was landing just about the same time as the 1 metre plus issue. And the problem we had there was that there appeared to be a view permeating through, and a real concern and risk that it was being conceived that if you did 1 metre and you wore a face covering slung around your cheek or whatever it might be, that was fine. And so there was a risk that in encouraging face covering, people would stop doing the thing that was really important, which was distancing and all the other things. So this may have been coming on the back of that. I suspect it was.
So the risk being a full sense of security?
Yes, a full sense of security, but it was actually also overlapping with what was economically driven policy, I think, to try and remove some of the distancing rules. So it was, you will have seen, I think, in the evidence, I think it's about this time with Jonathan Van Tam and myself, where we were trying to really highlight what we thought about the 2 metre and 1 metre rule discussions. And what was being conceived was, if you wear a face covering and reduce everything to 1 metre, the face covering will make up for the difference. And the answer was, no, it won't, and it definitely won't if it's not evidence-based.
Well, in fact, that was the point I was planning to come to, Professor, which is... No, but it's the point about false sense of security.
Yes.
What we are seeing here is draft guidance on making a mask, which will, of course, make people feel more confident to go out, to go on public transport, whatever, which you are saying is ineffective. So wasn't that a reason to say, no, we shouldn't be encouraging people to use these ineffective masks?
That's a very difficult balance for the point we've just come back to, because the first question was, shouldn't you be encouraging them if there's no harm? And the issue for me at that time, and I think Professor Van Tam shared it, was we definitely shouldn't be supporting something which was not evidence-based if it was going to promote a risk compensation. And there were a number of different driving factors here. And, of course, face coverings, as I know you'll be aware, is a wholly polarised debate, and it's quite difficult to maintain a central position. If I'd said, don't do any of this, somebody would have challenged back and said, well, surely it does no harm. My main concern was it was being put in or it would have been conceived as a safer way of moving about just when we got through the first tragic wave of the pandemic.
And did you do something about that concern?
Yeah, well, on the 1 metre, 2 metre, and I think this is, I'm maybe getting my timeframes mixed up, but I think this is very much around the same time that the CMO, CSA and 2 deputy CMOs wrote to Simon Case, because it was around lifting all the different industries and businesses and sectors at the same time. And the anxiety was that if people just thought they could get a bit of T-shirt, put it round their face, and that would solve all the problems and we could go back to normal, that was not going to be a good public health intervention.
All right. Professor, lastly, I want to ask you about a different matter altogether, and it relates to your current role with the UKHSA and some evidence that Patrick Vallance gave. So Patrick Vallance, when he was in the witness box last week, and he was talking about how the country might best prepare for a future pandemic. And he talked about his idea of a need for something that he described as an academic centre for pandemic preparedness, in terms of trying to bring together in one or more academic institution all the different fields of expertise that might be relevant to preparing for a pandemic, whether it's modelling or testing masks or all the whole range of expertise. And when I asked him whether that was something that the government should be involved in, he said yes, he thought it should have government funding, and indeed he thought the UKHSA, your organisation, should be involved in that enterprise. What's your view about all of that?
So I think Sir Patrick and I are looking at it from slightly different lenses, but the broad answer is yes. And in fact, it is in my planning. But what we have at the moment, just by way of description, is a number of different universities across the country have set up their own pandemic institutes, or words to that effect. We are linked to them on an individual basis, and they link with each other. The vision from my lens is that they have a network. They all have brilliant academic work ongoing routinely. We are sitting almost at the interface between government and academia. And so in peacetime, when we're not all responding to something, then we can be identifying between us what pieces of research work need to go ahead. There's opportunities to link with National Institute for Health Research and funding opportunities. So we're all aligned on what the priorities are. And then at a time of need, actually the global institutes are all there to work through and with UKHSA, working into the pandemic response, for government. And it wouldn't just be for pandemics. If you thought about something like the Mpox epidemic recently, then it's a great opportunity to do that. The only thing I would say is I think Sir Patrick suggested, and I noticed Graham Medley said, well, they were expected PHE to be doing a lot of the work for SAGE. In fact, PHE was doing a lot of the work. It was going in on individual names to NervTag, and then the NervTag paper would go to SAGE. And so a lot of the academic work, it has not been recognised of PHE colleagues, and I would just like to pull that out.
That's a comment about the last pandemic.
It is, but on this one, now there are health protection research units. They've actually just been refunded. We have a lot of people who, I call them twin hats, so they work part-time in the UK Health Security Agency, they work in academia, and the health protection research units can do very rapid evidence reviews or research programmes. Many of the urgent research work that was done through the pandemic is done through those. So my shorter answer is, to be helpful, is I absolutely agree with Sir Patrick. We're trying to do the same approach with industry so that we're ready to create vaccines, look at therapeutics. I think there is a partially set up system already. We have our own Centre for Pandemic Preparedness, which is designed as the building block to link with academia already. It's not funded longer term, but nevertheless, we have prioritised trying to put it together because we also think it's really critical. So I think it's a version of what Sir Patrick has mentioned, and I think we've started to build it already. So I perhaps need to swap notes with Sir Patrick so we've got a consolidated view.
Thank you very much, Professor. Those are all my questions.
Just before I go to the questions from call participants, Professor Harris, you talked about lessons learned. Have you thought of a list of lessons that...
So I think I put 3 in my statement. One is very much around data. One is around science and the value of the scientists. And the third one is inevitably, you will see, around social care. If I work backwards, I don't think we can have a responsive health system, health and wellbeing system, if the value of social care is not recognised and the value of the workers is not recognised. As I look forward, planning for pandemics, the very same frail individuals who are sitting in residential care settings now, or learning disabled, who wherever they may be in the community, are the same people I need to reach each time there is an infectious disease incident. And so that should be much better planned for on a systematic basis. And I think social care workers should have parity. That's not how it's been seen. Second point, I think, is around data. There are a number of reasons why data appeared to flow slowly. Probably not for going into the detail here, but there should definitely be a transparency of data. But we also need to engender trust, I think, in people sharing data. One of the problems, for example, with ethnicity is yes, people aren't looking to collect it. That's a problem for researchers, for government, but also people need, we need to enable them to feel they trust us to share that data so that we can actually get the granular level of information to support them. And then the third one is, although we are a response organisation for infectious disease, we also have a significant scientific element. Our scientists are just not recognised. They're sitting at the back of this. Every time somebody uses a point of care test, it will have been validated at UKHSA, put down. Every single vaccination programme is, there is a whole pathway. No vaccination programme in this country is running without colleagues working at UKHSA, Colindale and across the UKHSA generally. These are quite hidden scientific tasks. One of my problems actually in setting up the organisation is having funding for a year, not having that view. A scientist has a 10-year career ahead, and you need to do 3 years of research, and that needs to be really, really embedded, and then we can take forward our work with industry as well, I think, and work with them.
Thank you very much. Mr. Wilcott.
Professor, good morning. I'm going to ask you some questions on behalf of the Northern Ireland COVID Bereaved Families for Justice campaign. And I think you've had advance notice of the areas that we wish to cover. And they really deal with your involvement in UKHSA, which you've just been talking about. Yesterday, you told us that you became Chief Executive of the UK Health Security Agency in April 21, and that body became fully operational in October of the same year, and that the UKHSA took on much of the health protection areas that had previously been the responsibility of Public Health England. The inquiry has heard expert evidence from Professor Ailsa Henderson of Edinburgh University that despite the name change, which was designed to enhance clarity about the territorial extent of the role UKHSA played, the body still has, in her words, a predominantly English focus, using and analysing English data, and therefore framing an English framework in response. Can you see the force in those observations?
Yeah, I probably should just declare at this moment, I'm a Welsh resident when we get into questions of 4 nations. So I look from both angles. I trained and I live in Wales.
Well, we'll forgive you that.
No. I didn't choose the name. There are clearly huge advantages of working across the UK but in relation to things like pandemic response, and I absolutely welcome what is actually very, very close working, particularly with the CMOs and deputy CMOs, but also with the health professionals in the different health protection agencies. Is a very, very positive working arrangement. They happen naturally. However, I think there are points that have been made, and they're recurrent points, and so I'd look at them in two ways. One is the Joint Biosecurity Centre, which I think was welcomed by, I didn't set it up and I wasn't there, was welcomed by other UK nations, had a formal agreement, and that agreement is maintained. It was agreed by the health ministers, and then there is a working level board sitting underneath that. We also have a separate UKHSA devolved nations board, and in fact it met yesterday. It's chaired by my Director General for Strategy and Policy, and that met in Edinburgh. So I think that in itself should signal the steps that we're trying to take to maintain it. When it comes to data, it gets very, very much more difficult. So, for example, we saw discrepancies. I was expecting somebody to ask me about Q-COVID and shielding and various other things, but a Q-COVID tool, for example, we had in England and we had in Wales, we didn't have in Scotland. That's not because people weren't working together, it's because the systems are different, and each country has its own health protection agency and is responsible for its own health protection response, except for some matters of global health security when we do represent the UK government, and therefore we are UK. So it's quite a complex setting. There is also, I mean, I can see this from the Welsh lens as well, having sat there. There's often a requirement or an ask, and we welcome in those colleagues. You know, there are instant meetings running now, and every nation is involved. But the data belongs to those nations, and if it is not provided to us, we cannot put it on various websites. I actually tried last night to put in my own postcode into the dashboard to see what happens, and I can pull up my own data, but it's not a landing page for Wales, for example. And Wales has some great scientists, they collaborate with us, but it's not a one-way flow. And I think the other thing is there's often an ask, which we've heard through the pandemic, through the inquiry, for people, you know, have you got somebody from Wales? Have you got somebody from England on a particular group? But if you want, it doesn't work the other way around. So there's an expectation everybody will come to England, but not that England will be allowed to go to every nation. So I think that's not a, you know, as I say, we work brilliantly with many colleagues and hugely grateful for their support. They're particularly good input to the social care working group. But it's something that I think is not a one-sided picture, and we need to work through how we can improve that.
So would it be a fair summary of that answer? It's a complex problem. You see some force in what the professor says,
yes,
and you're trying to put in
absolutely
step. All right. Now, I think you might have touched on the next question I'm going to ask you, because some of the families I represent have noticed that if they go onto the UKHSA website, there is no reference to Northern Ireland, Scotland or Wales on the website. And nor does the website direct readers from those parts of the UK to the equivalent services in Scotland, Wales and Northern Ireland. Are you able to confirm that that is the case, and if so, why would that be the case? Well,
again, this is one of these areas where it needs both angles, really. So I think if I was sitting, if I'm sitting in Wales, working as part of the health system in Wales, I think they expect residents to track onto their system. You know, similarly, I know there have been comments about press briefings, for example, over the pandemic, but of course each country also had its own press briefing. So it gets quite difficult. I would like to, we're still quite a young organisation, I would like us, with the very strong support of other health protection agencies, to make sure that as a minimum we have the links operating across and we're directing people, because at the end of the day we're all here to protect the public, and if they can't actually work their way around this very complex system, none of us are doing a very good job.
Understood. Let me just rewind a little bit. Presumably this concentration on English-focused data also existed during the pandemic.
So that the data, so the Health Service for data, for example, for, well, I'm using Wales simply because I'm very familiar with it, but it's owned by Wales. It's not our data. As I think we heard from Professor McLean last week, possibly, DSTL actually helped in the early phase get some of that data together, and she gave some reasons as to why it was easier for that organisation to do it than others. But it needs both the will of the trust, I think, of each nation to share that data, and it does get very sensitive. It happens within the UK as well, because for something, I'm going to be quite outspoken here, as politically sensitive as the National Health Service and its efficiency in all nations, that can be quite a challenging thing to do.
Was anything else done to try and rectify those problems, apart from what you've just told us,
Yes.
Dr. McLean?
So on the through the pandemic, obviously the dashboard actually did give different country data as well. So we did accumulate it, and I think it was shown, if I remember, at the number 10 press briefings, for example. You could see some of the countries, and it was looked at routinely, and colleagues from the 4 nations also reviewed. So when, for example, gold and silver committees were meeting, what have you, it would have input from all the different nations. But what we're displaying where needs agreement across all 4 nations. But certainly from my perspective, it would be much better if we had more sharing. I live on the border, so I'm a resident who wants to see and know what's happening around me.
So finally, can we assume, therefore, that if the UK HSA is to remain a UK-wide agency, you accept that more can and should be done to try and consider and reflect the UK-wide position?
Within the remit which we are given, which is not, it's to respect and work with the other health protection agencies. We don't have a control over.
Thank you very much.
Thank you, Mr. Walker. Mr. Freedman.
Professor Harris, I act for 4 national disabled people's organisations. You've explained in detail in your written and oral evidence that there were foreseeable risks. I think the words used today are normal things to think about if you were a public health trained. That social and health inequalities would produce adverse outcomes for people in terms of the virus itself and in terms of its countermeasures, and that would include disabled people. The question is this: why do you think now, with the benefit of hindsight, there was so little government planning for that?
I think I look this way, is that right?
Please face away from me to the chair.
So there was a lot of planning, and I don't think, I wouldn't wish the inquiry to think there was no planning at all, but I do think we can do better. One of the things which actually I think is very positive in this regard, which I was personally involved with and which the CMO started, was the tool called Q-COVID, which I've just highlighted. The shielding programme was, I think, has had a quite difficult birth and utilisation because people have used the word shielding. We've heard segmentation, we've heard shielding, we've heard cocooning. From my perspective, there were 2 elements to it. The part I was involved with, which was very definitely, clumsy words, but to distinguish clinically extremely vulnerable and clinically vulnerable. That was to identify people with diseases, some of whom will have disability in higher rates. And then there were other vulnerabilities, some of which will have been disabilities, some of which will have been financial disabilities, if you like. So there were there was a difficult mix, I think, between the clinical provision and recognition and the work which was ongoing in local government. But I think there's an opportunity for us to actually get that better aligned. And what we did do, I think it was Michael Marmot in the first inquiry said that nobody had actually, it was all clinical and nobody had put the rest of it together. Actually, that's not correct at all. What we did do was, at the first round, if you like, thought, who do we think is clinically vulnerable? And that will include quite a lot of people with existing disabilities. And then we went on, having started that shielding programme, to develop a weighted cumulative risk tool. It's called Q-COVID, but without going into the detail of it, it was for two reasons. It was to ensure that people could have a conversation about their own risk, and it was to ensure that we had captured as best we could the intersectionality of the problems that people might have. Now, some of these will include disability. So the one that I'd particularly call out, for example, is learning disability. And that tool also included socioeconomic deprivation and ethnicity as best we could. And so through that, we actually added on a significant number to the shielding patient list, so not just for clinical reasons, but for many others. And we also moved up a lot of people into the group 4 for the JCVI vaccination as soon as that was through.
Thank you. I'm just going to come in there, and in due course we'll go through the timeline with the chair on the documents. But I think you know very well that as of March, and let us say the 16th of March, for instance, because you looked at very difficult emails to look at now, where you had to give very high-level, realistic advice. You've explained something that was developed, and I think you know, from July into September and into the autumn of 2020. I'm not asking you about that. I'm asking, and maybe you disagree with the premise, but we rather thought it was clear from your statements that normal things to think about if you were public trained were not normal things that government as a whole was thinking about as of mid-March 2020. And the question is, why do you think now, with the benefit of hindsight, that there was so little thinking about that across government at that time?
I would say, I certainly, having worked in local authorities, I think local government definitely thinks about it.
But I'm asking about central government, which is the module.
I agree, but I'm not sure I can answer that question in that way, because it's not I'd be asked for advice, and I would give that willingly. It's not an area that would be directly involved with me. I mean, I know right at the start of the pandemic, the Minister for Care asked for reports as soon as there was any evidence that could be used around disability. The data is quite difficult, and of course, something like, I think it's 65% of those over 65 will have disability. So to some extent, they were already being thought through in the shielding programme.
Just on that shielding programme, the meetings from early March adopted a two-tier approach to shielding, and you've explained there was some baggage in the label. We understand that. And there were going to be different degrees of clinical vulnerability. Now, was there a foreseeable risk that those in the second tier, however one defines it, would be deprioritised in being able to access basic services such as food and healthcare services, access to which was explicitly linked initially to being within the first tier, clinically extremely vulnerable cohort?
I might not have quite understood the question. So tier 1 is the
CEV.
Yeah, okay.
And they got an automatic package, and
yes.
CV didn't.
I mean, the important thing here is that shielding, as I think Professor Whitty said, is not. I mean, basically, there isn't a magic bullet here. It's somebody is advised, and totally for them to do completely voluntarily. This is not the sort of segmentation policy that I think is described elsewhere, to go into isolation almost. And so it is firstly for them to choose whether they do that, always has been. For those who are in the clinically vulnerable group, the wider one, then there was obviously it's a much wider group. We recognised that we couldn't contact all of those people centrally. It wasn't feasible. And for the reasons which I've just said, that intersectionality of risks was very much something for local government. So it's not something that was handled in that way. So there were funding to local authorities, but I think you'd need to direct that conversation to somebody from that department. And
understood, but conceptually, as it were, at the central level, yes, reliance was going to have to be placed on the effectiveness or otherwise at the local government level.
I think that's right. And I mean, local government they run, and I'm sure you're aware, they run registered. They will know where their local communities are who need support. And those people sort of running between both a clinical risk and, a financial or mobility risk.
Well, we can look at that in due course, and we've heard what you've said about social care and the lessons learned about that, and the parity that's needed now that perhaps wasn't there then. So, but staying with those who were regarded as clinically vulnerable and with what degree of risk, may I end by asking you about Down syndrome? Mm-hmm. And I think you were on notice that we wanted to ask you about this, and we've got quite specific questions, if you could assist us on them. The first is this, it's levelled at March 2020. I'm going to go on in the chronology. So the first one is, bearing in mind that respiratory disorders are a predominant cause of death for people with Down syndrome, should they have been designated in a higher category of risk from March 2020?
We had to look at what was likely to be a risk factor at the start.
Yes.
So I don't think there's any suggestion of perfection in that.
No.
The Q-COVID tool was designed to enhance that. Not everybody with what you might think, and I think, is it Professor Breitling said this earlier, would necessarily, some of the things we found did not work out. So, for example, we thought people with asthma might be particularly affected. You'd think respiratory disease. Actually, that wasn't for most people. That wasn't it, and they could come off the list. So for Down syndrome, it's not that there was very little signal to start with. So there's a logic, and there is a potential logic for a number of conditions. What we did do was to monitor these things. So there was a 4 nations, goes back to the question earlier, there was a 4 nations UK clinical panel, which I chaired. In fact, the signal from Down syndrome was raised by nerve tag, I think. So time for it to come through around May. We asked the clinical lead for the NHS to bring forward a paper, and all of the clinical leads for that UK panel met and reviewed it. Now, at the time, there wasn't sufficient granularity in that information to be able to see a signal, but there was a process of bringing things back. And a couple of months later, there was a signal through, and immediately all the Down syndrome people were moved onto the shielded patient list.
Thanks. You've gone ahead a little bit. I'm just going to break that down a little bit, because that's what I'm going to ask you about. We know it. Hope you'll just take this from me. We know as a matter of record that Down syndrome was not added to the CEV list until early November. It's about 2nd of November.
Yes, although every
Can I just set the context for you and tell me if you disagree? You've explained to the chair, as we understood it to be, that the matter made it to the nerve tag clinical subgroup. It's actually first at the beginning of June, and then going to a second meeting at the end of June, 29th of June, where they indicate on the basis of modelling that there appears to be a high risk, but they want more work to be done, and they pass that up the line, as you've just summarised to the chair. So we've got to the 29th of June, and then there is a there is a decision that goes before the COVID O group as of the 1st of October that is indicating that the work has now been done and the recommendation is there in the pipeline. And then we have, as it were, this letter to the GPs and other stakeholders as of the 2nd of November. So we've got a very specific question on that, which is, how could such a delay in adding people to the Down syndrome CEV list have been avoided? How could it have been done quicker? Now we know, and that as of 2nd of November, what had to be done had to be done. How could it have been quicker?
So, number one, just for clarity, if a GP felt that somebody with Down syndrome, for some specific reason, because many will have other conditions, so epilepsy, for example, needed to be on the list, they could go on. But on your particular point, I think I tried to explain, obviously very badly, that in that intervening period, the detail had been looked at. It had come to the clinical panel. It had been presented to the UK CMOs. The signal wasn't there at that time, and as more data came through, it went back again in September, and we immediately acted on it because we could see that the signal then for Down syndrome was high, and then all of the Down syndrome adults were put on the shielded patient list. So it's not that there was no activity, there was actually a systematic approach to looking at the evidence.
We understand that. The point of it is the paper in September showed a 10-fold increased risk for people with Down syndrome.
Yep.
That's a very significant risk. That's a paper in September.
Yep.
The CEV moment is the 2nd of November.
So
I think you're trying to tell the chair you went quickly. In your view, my question is, how could it have been done quicker? Your answer may be it couldn't have been, but that's the question.
So there is a process. I've got a date here of the 9th of October, and I think the process for moving the people onto the list started. So there is a digital process to do that. The other point was, I think, just for reassurance for those individuals, that was, of course, the time when no shielding was in process. So I think what we were trying to ensure was individuals were on that for the list going forward. It had been paused over the summer because of the lower prevalence rates.
Right.
Thank you. That's enough, Mr. Friedman. Sorry, thank you. Mr. Thomas.
Professor Harris, good morning. I represent FEMHO, Federation of Ethnic Minority Healthcare Organisations, and as you probably know, FEMHO represents and advocates for the interests of workers from ethnic minority communities at all levels within the health and social care sector across the UK. I'm going to be making reference to your fourth witness statement, but I'm not going to call it up. But just for the record and for her ladyship, the relevant paragraphs are paragraphs 9.38 and 9.40. Here's what I wish to explore, and let me just set out a little bit of context, and I don't have much for you. During the pandemic, when the NHS was overwhelmed, care homes were meeting the deficit in terms of the NHS's ability to care for often elderly people, some of whom were dying and would ordinarily be in hospital. You would agree, I'm sure, that that situation would have had a significant impact on care homes. Can we agree on that?
Sorry, I'm not being awkward. Can we just go back? So,
of course.
So I would expect anybody who would normally be in hospital would be in hospital unless there was a reason not to. I may misheard. Could you just go back one and then
Of course. I'm suggesting to you that the NHS was overwhelmed.
Yep.
Care homes were meeting the deficit at times in terms of some of the NHS's ability to care for often elderly people, some of whom were dying and would ordinarily be in hospital. That's the proposition I've put to you. Do you accept that or don't you?
I would hope that, except in extreme circumstances, they would be in hospital, that it should be preserved for those who will be benefiting from that. But I agree the whole system was under stress.
All right. In the light of the unique challenges posed by the global pandemic and the national emergency it represents, I'm sure you'll also agree that central government should bear significant responsibility for ensuring that the safety and well-being of its care home workers, especially considering their frontline roles, being in an overstretched public service. Would you agree with that?
I mean, I think that is a question for the government, the minister, rather than me as a medical professional to answer. But having said that, I suspect the statements that I've made earlier suggest that I, as a public health professional, are very much in support of ensuring that the care staff are recognised.
Is that a yes?
I don't think it's a question for me to answer on behalf of government. It feels like it's a ministerial question. That's the only reason I'm not commenting.
Well, the reason why I'm putting this to you is because something that you've said in your statement at paragraph 9.38, and I'll put my second question to you. Would you accept this? Given the critical nature of care home workers' roles, particularly during these extraordinary times like a global pandemic, it would become imperative for central government to take a more active and central role in overseeing and supporting the safety for care home workers. Would you accept that?
I agree, and I think they did. They certainly tried to. I also would flag, which is the point in the lessons learned, which is the underlying system for care homes in this country is not one of central control. It's very different to the NHS.
Well, I'm going to come on to that because that's my final point, which is because you make this point, and this is again at paragraph 9.3.
Is it possible for me to see what I've said because I don't have it in front of me?
I'll come on. This is what you say. You say that while recognising the private business model of care homes,
yep.
Yes, there it is. It's in front of you. Yeah. You say while recognising the private business model of care homes, here's the point that I wish to put to you. Surely we can agree that government decisions and policies during a national emergency can significantly impact the ability of care homes to protect their staff, manage PPE stock, and ensure business continuity, thereby necessitating a more engaged role from central government.
Yeah, so I would just say I do think this is a question for government, not for a medical advisor. Of course, I think the government would say, and I mean, I'm sort of answering your question indirectly, that they have and that there was clearly a central role in the pandemic. But the point I was trying to make is probably the one which I think you're getting at, which is the model was not one that was established well enough to ensure that that central control happened effectively. And that, I think, is one of the points I've put in my lessons learned because it's so critical because of the vulnerability of the population.
Thank you, Mr Thomas. Ms Sajid, can you see? Sajid is over there.
See me, Professor?
Yes,
Do say if you can't see me.
I can. Thank you.
I represent Southall Black Sisters and Solace Women's Aid, and I'll be asking you questions relating to domestic abuse as a public health matter and key workers. So my first question is at paragraph 445 of your statement, dated the 22nd of August 2023. I know you've done a few statements. You say that on the 16th of March 2022, Public Health England explained that testing was being scaled up to focus on intensive care units, hospital admissions, and testing for key workers. Did you have any involvement in defining key workers?
I presume you mean 2020. I think you said 2022, but I presume this is
2020. I apologise.
Yeah, the change in prioritisation. Yeah. Not directly. I was engaged in discussions over the pandemic with things like testing for key workers, but very much from, at that stage, the technical advisory part of what would work. There were discussions across government, but it was, and they were right across all sectors. So I was in the room. I wasn't a key decider of who was in a key sector.
Okay. So although you weren't a key decider, as far as you are aware, were those working in refuge accommodation or domestic abuse charities prioritised for testing? And if so, when was that?
I can't answer that one directly. I mean, there are two issues there about key workers and who was a frontline worker, and then sort of the implementation of the testing programme. There was quite a lot of consideration, I think, in NHS Test and Trace. Again, I wasn't there at the time, about where that risk lay and who needed to be tested. And obviously there were many different use cases, and there was a certain flexibility whilst working with Directors of Public Health that if they wished to, if they could identify groups, because it will, as you know, vary in different geographies, that they could direct testing in those cases. But I think that's probably all I can say to help.
I'm going to turn to my second and last question. In his evidence to this inquiry and in response to questions relating to interventions, NPIs, so Chris Whitty said that he is entitled and should weigh up the negative aspects from a public health view. He gave an example of people who go into shielding before needed and then end up with loneliness and depression, and that these are clinical and public health problems. Now, I appreciate you briefly touched upon this with Mr O'Connor, but given that domestic abuse and its impact on victims are public health issues, what should the government have considered in relation to domestic abuse when deciding social isolation and or lockdown measures?
Well, I think I probably have answered the question, because in that particular case, to my mind, it is foreseeable we can imagine what's going to happen. And I think you will probably be representing people who experienced those increases in calls just beforehand. And therefore, I think some of the messaging was not as clear as it could have been. To make sure that people understood that they could come out of isolation. There clearly was a course out, and I think it was considered within that. I'm not sure that if I was somebody frightened, in a domestic abuse situation and about to go into lockdown, that I would perhaps have clocked that the message that says for an emergency actually applied to me.
I'm grateful, Professor.
Thank you, Mr. Sajid. Mr. Stanton.
Thank you, my lady. Good morning, Professor. I'll be asking a few questions on behalf of the British Medical Association. I'd like to ask your views about the response to the risk of airborne transmission, avoiding any duplication of this area when you were engaging with Mr. O'Connor. At paragraph 521 of your first statement in this module, you indicated that this risk was predictable in February 2020, but took some time to determine. And appreciating that the scientific understanding took some time to play out, can I ask you why a more precautionary approach wasn't taken to this risk from the outset?
So I think we heard yesterday, I think, or from a previous witness, it was treated as an HCID to start with. I mean, that has a whole discussion in itself, which I won't go into. So I think it was treated with a precautionary approach. That was correct. And when I say it was foreseeable, I think it was because almost any respiratory virus, we would expect it would be very difficult to not think through a whole continuum of going from, fomite droplets and airborne. The critical thing here is about the proportionality. So I think the right preventive element was put in to start with, and it is a matter of the developing science as we've gone through, which is very complex.
Thank you. Thinking about the measures in place within healthcare settings, what prevented the provision of FFP3 respirators to healthcare workers who were treating patients with COVID-19?
So the guidance, as you will know, I'm sure, was reviewed multiple times and continues to be as we have gone through. It's set by a Four Nations IPC cell, not by myself, not by Public Health England in those days, now UKHSA, and the operational implementation of that sits with NHS England. So I can't. I mean, there's a very, very complex review through that. It goes back to the risk and the evidence. So FFP3s were provided for aerosol generating procedures right from the outset. That has always been there and it remains. And we are back then to the balance of risks around appropriate PPE. But I would just like to say that at all times, when those reviews have happened, they have linked across to see what WHO is recommending and have stayed consistent. I'm pretty confident on that. So I think one of the interesting things was FFP3s and FFP2s are used differentially in different countries. So in fact, the FFP3 that was in play right at the start of the pandemic is if you like, in simplistic terms, a stronger recommendation than in many other countries, and I think for some of the WHO guidance.
To what extent did cost and availability play a part in their provision? So
again, as I said yesterday, I wasn't responsible for PPE. Obviously, some of my team now input to the technical side of it. Cost was not an issue at all in any of these events. So that one is right out of the picture. But obviously, there was a global shortage. I mean, I think if every country in the world wants PPE, it's going to be difficult. So I think at times there was difficulty procuring. That said, as I discussed yesterday, certainly early on we did have a very good national supply, but obviously as it was pulled on, and I think picking up the care provision, the pandemic preparedness PPE was predominantly, I think, originally focused on healthcare, which goes back to my point about social care.
Thank you. Lastly, and very quickly, just picking up on some of your comments you made about the effectiveness of masks used in the general population. Can I ask you your view of the effectiveness of fluid-resistant surgical masks for combating aerosol transmission?
I mean, that's quite a detailed technical question, which is probably not for answering here, and I'm happy to provide a written one on that. I mean, usually there is, when you're working in a healthcare environment, often the fluid resistance is there for splash protection, but obviously if the splash protection is critical, then you will actually have a shield as well. So, it's quite a detailed answer. I'm very happy to provide one in writing.
Thank you. Thank you, Melanie.
Thank you very much indeed, Professor Harris. I wish I could say it's the last time we're going to call upon you, but I have a feeling that we'll be asking you to help us again. Thank you for your help.
Thank you.
Right, I shall return at 20 to 12.